Good afternoon, everyone. I'd like to thank the organizers for the opportunity to be part of this prestigious meeting. So I'm here to talk about or share with you some tips in myopic macular hole surgery. It's a myopic macular hole. It's a condition that can be challenging because of the structural changes in highly myopic eyes. Okay, so here are my tips. First is to conduct a thorough preoperative evaluation. So we need to be able to prepare the right instruments for the right axial length of the eye. Gauge 23 and 23 gauge and 25 gauge vitrectomy probes. The lengths of the shafts, they appear similar, but take note that with 25 gauge, there's a stiffening sleeve. So the effective shaft is much shorter compared to the 23 gauge vitrectomy probe. Myopic patients, they tend to have vitreoschisis. So triamcinolone is a valuable we can use it to visualize better the vitreous and do a complete vitrectomy. Contact lenses can be used to enhance our depth perception. It's easier to see the ILM, especially in myopic patients wherein the retina tends to be thin and tessellated, so sometimes it's very hard to identify the ILM. There are times that we need to restain the ILM after the first attempt because it can be the staining can be unsatisfactory or insufficient. And for myopic macular holes, we can consider a larger area of peel to relieve the tangential traction and probably increase the closure rate. For myopic patients, it might be better to suture the ports because myopic patients, their sclera tends to be thinner to avoid the risk of hypotony. And we need to inform our patients that macular hole closure might take longer compared to idiopathic macular hole. So I'm sharing a case. This is a case of a 63-year-old female with pre-surgery visual acuity of 20/63. Her axial length is 29.8 as measured by IOL master with a refraction of -16. Anterior segment findings were unremarkable except for mild nuclear sclerosis. On fundus examination, the disc is tilted with generalized thinning of the retina, especially at the area of the macula. On OCT, there's a full thickness macular hole and maculoschisis. So the surgical plan for this patient was 23 gauge PPV, inverted flap, and SF6 tamponade. So here's the case. So first, again, choose the right instruments. And then do PVD. You can use triamcinolone again to visualize better the vitreous. And then choose the right stain. So I used brilliant blue staining. When we inject the dye, take note of the pulsation of the optic nerve. So better to use contact lens for these cases for better visualization. So I did an inspection of the ILM but was not so happy. So I restained with a brilliant blue. So luckily the second staining was okay. So I'm comfortable using Alcon Gray Schaber forceps. So take note that for myopic patients, their ILM tends to be sticky, more adherent, more fragile. May I have a minute, please? Okay. More fragile. And for myopic macular hole, I tend to do bigger flaps and then save the flap to cover the hole. Okay, so I was trying to enlarge the peel here. So more peeling. Can we adjust forward a little? Okay, I did air fluid exchange And then one technique is to keep it really dry, to position the ILM over the hole. So to avoid inadvertent aspiration of the flap using your silicone tip cannula, I fill it with gel before doing the massage. Okay, and then suture the ports with Vicryl. So for this case, 2 weeks post-surgery, it was like no change from the pre-operative OCT. But serial OCT showed at 6 months, there was closure of the hole. And at 7 months, there was complete closure with a visual acuity improvement from 2050 to 2030. So thank you so much for your attention and hope to see you in Manila this December.
Thank you, Joanne. Nice presentation. I know those are tough cases where you deal with myopic cases, posterior staphyloma, atrophic RPEs, and macro hole, all those tough combination. So I'll open the floor for questions from the panelists or comments.
Yes, I'd like to ask you, did it happen that you did not succeed to remove the ILM in those very high myopic eyes with posterior staphyloma?
Oh, I think in the 2 weeks post-operative OCT, you can see the ILM bridging.
No.
No,
I'm
in
asking,
different cases.
during surgery, did you sometimes do not succeed in removal of the ILM in those patients with high myopic eyes, posterior staphyloma?
Okay, well, luckily, there's not much cases of myopic macular hole, okay, in the Philippines. Not that high numbers, okay. But so far, with my patients, I've been I've been lucky so far to have a good closure rate.
Thank you.
Yes, Dr. Sama.
Thanks for this excellent presentation. I have a question. What's the explanation for delayed closure of this myopic macular hole? I totally agree that using contact lens such as HT lens or Versa lens makes life much more easier during surgery. But usually we have a closure rate more earlier in case of idiopathic holes or myopic holes. What's your explanation for the closure for 7 or 8 months later?
I think because compared to the idiopathic macular holes, the traction, there's a posterior staphyloma. So aside from the tangential and the anteroposterior traction from the vitreous, there's another component of the curvature of the posterior pole. So maybe that's one of the causes that myopic macular holes, they tend to close longer compared to idiopathic holes. Any ideas from the other panelists?
And actually, I have the same question. So 6 months is a long duration to wait until to decide to re-intervene again with a second surgery. So which patient you decide to wait, and which patient you proceed with second surgery within, let's say, 2 or 3 months? Okay. Because you cannot wait for the patient, keep him every, day and night, he calling you, my macula is not yet closed, surgery is not successful, and so on.
Okay, I think one good way is to do serial OCT. So like every month, you can do the OCT and check, like for this patient, the maculoschisis, the height of the schisis was decreasing every month. And then you can see also the distance from the edge of the hole also becomes smaller. So maybe if 2 months, it's totally the same from the pre-operative OCT, maybe it's time to intervene.
Thank you, Joanne. Thank you very much.
Thank you.
Thank you. And now it's time to close it and glue it.